So why do we place implants? Of course, to replace a missing tooth. Here is a really nice schematic showing an implant being placed into bone, and here is a radiograph of the finished result with a restored implant crown. Contraindications for placing an implant, we have a list here: uncontrolled diabetes and immunocompromised patients. These are both at higher risk of infection. The volume and height of bone needs to be sufficient in order to support an implant. Bisphosphonate therapy, that patient will be at risk of bisphosphonate-related osteonecrosis of the jaws or bronch. And you may be noticing that a lot of these are contraindications for tooth extraction as well, and there's quite a bit of overlap between these two lists. Bruxism, a patient who is constantly clenching and grinding their teeth, may not be the best fit for an implant. Smoking is a relative contraindication. Again, all of these are relative contraindications. A history of head and neck radiation, another familiar site from the tooth extraction contraindication list. Patient with cleft palate, and adolescents. Adolescents are not done growing, so if we place an implant in one part of the bone, as they continue to grow and their jaws continue to grow, that implant may not be in the place that we want it to be. So we need to wait until 2022, 24, until that bone is completely done growing and we don't have to worry about that implant moving around. Now, along with age, old age is not a contraindication for placing an implant. Just because you're older doesn't mean you can't have an implant and can't have a really nice result with an implant. So you may get a boards question that poses a scenario where you have an older patient, and that alone is not a contraindication for receiving an implant. All of these are relative contraindications. So we have three main categories of implants. These are big picture categories. Subperiosteal, and if we unpack this name, that means under the periosteum, and it literally rests under the periosteum layer. And so it's not screwed into the bone at all. It's laying underneath the periosteum just like a blanket. And this metal framework has extensions that poke through the oral mucosa, shown in pink here, for retention of a prosthesis. So there's no true osseointegration with this implant. We'll talk about osseointegration later in the video, and therefore has a very poor prognosis. So it's rare to see these around at all today, and that's because most of them, if they were placed a while ago, have since failed, and they are not a great option for implant therapy. Next, we have transosteal or transosseous. Either way you write it, that can refer to trans meaning through and osteal meaning the bone. So these implants are placed through the bone. Now these are exclusive to the mandibular anterior region because it requires an extraoral approach. You drill this one through the inferior border of the mandible and into the oral mucosa. Usually they involve 2 to 4 transmandibular implants in order to support a larger framework. Again, these are very rare, it's a very involved surgery, and do not have great success either. So that leaves us with the third category, endosteal or endosseous. We unpack this word, it means into or in the bone. And so the endosteal implants are placed into the bone. Now these are available in many different forms. There's a blade shape, a ramus frame, and the ones that are depicted here that we see by far most often, and what we'll talk about throughout this video, is the root form implant. It's generally cylindrical, and it's called a root form implant because it's shaped like a tooth root. And so let's talk about the endosteal implant. So an endosteal implant has 4 primary components if we boil it down. And from bottom to top in the schematic, we have the implant body, the abutment, the abutment screw, and the implant crown. So now in the next couple slides, let's unpack each of these components. So the implant body, also called just the implant or the implant fixture, is shown here in the top right. It's usually axis symmetric, which means if I were to draw a long axis down the center of this implant, it would be symmetric around that long axis. The basic procedure for placing an implant such as this one is to drill a hole into the bone, and we sequentially enlarge that osteotomy, which is a fancy name for the bone hole. So we start with a smaller drill, much smaller than the diameter of this implant, then we go to a larger one, and then finally one that's large enough to create a hole that will support this implant being drilled into it. So the reason why we sequentially enlarge the osteotomy is to, number one, reduce the amount of heat generated. And this helps to keep the bone cells alive, which we desperately want. And having a sharp drill and also using copious irrigation helps with reducing heat generated as well. Secondly, it helps to maintain the axis with freehand surgery. So what the heck does that mean? Well, when we're doing an implant placement, we can be using a stent or a template of sorts, and we'll talk about that a little bit later, or you can be placing the implant free-handed. Now, of course, you have radiographs, or better yet, a cone beam CT image, basically a three-dimensional X-ray, so you know how wide the bone is, how deep the bone is, and you know what angulation to place that implant at. But being able to check the hole at each step, you can check how you're doing with your angulation. So you start with a really small hole, you put in a little indicator, and you can say, well, my hole's a little bit too angled distally, so next time when I go up to the next bigger drill, I can correct that angulation. So it gives you some opportunities to correct and maintain a proper axis. The implant body is usually inserted into tapped holes, and a tapped hole in carpentry, or any trade for that matter, is a hole drilled prior to a screw being inserted. It's similar to a pilot hole, except that it has the threads cut into the inside surface of the hole. However, some of these implants are self-tapping, and you can see that by these little gouges that are made in the apical part of the implant. And so they essentially cut and create their own threads as they're drilled into the bone hole, and thus do not require this step. So that's some big picture information about the implant body. Now let's talk about the abutment. So the abutment is the part of the implant schematic here that is placed onto and into the implant body. So the abutment can be broken down into two big categories, one-piece abutments and two-piece abutments. So let's spend some time digging into the differences between these two categories. So the one-piece abutment combines the abutment and the abutment screw into one component. So if we go back to the schematic, that's combining the abutment and the abutment screw into one big piece. So the screw is actually a part of the abutment. And so the whole thing screws into the inside of the implant body. And this beautiful cross-section image here shows that abutment adapting to the inside of the implant body, and then that screw holding it in place. So here is the implant body, the abutment screw, which is part of the larger abutment. It has no anti-rotation component, which we'll talk about in a later slide. Notice it has a smooth conical shape, which is called a conus, C-O-N-U-S, that wedges into the top of the implant to ensure proper seating. Now, more commonly used is the two-piece abutment, And so the abutment is held to the implant body via a screw that goes down the center of both. So in the two-piece abutment, the abutment screw and the abutment are separate components. And so in the cross-section image here, you can see the outside of the abutment, which is here and here, interfaces with the implant body, which is this part here and this part here, and the screw, the abutment screw, that drills down the center of both the abutment and the implant body. And this is a bit difficult to comprehend, but if we break it down into the four major components of an implant, hopefully that can make it a little bit easier. So this abutment does have an anti-rotation component because you can seat it and lock it in place, and then place the abutment screw through that whole assembly. And again, we'll talk more about the anti-rotation component a little bit later and why that makes the two-piece abutment a little bit more desirable than the one-piece in most cases. And finally, let's talk about the implant crown. So the implant crown itself can be broken down into two categories: the screw-retained crown and a cement-retained crown. So for the screw-retained crown, we would place a screw through the crown into the implant. And in general, the abutment and crown of this type are fabricated as one component. And then the abutment screw is placed through the entire piece into the implant. So this is technically now we're combining the crown and the abutment components, and then the abutment screw, shown in gold here, is drilled through both of them. So this is technically would be an example of a two-piece abutment, where the screw and abutment are separate. Now, the cons of this type are that we have a screw access hole. And so the screw access hole is typically placed in the central fossa in the posterior teeth or in the cingulum area of the anterior teeth. Now, the screw and the access hole is very apparent and could create an aesthetic problem. And what we typically would do is place some Teflon tape into the hole and then place a composite plug to fill in the rest of the hole. So you need to position the access hole in a non-aesthetic area to avoid, even though you can match the color somewhat with composite, you usually want to leave it a little bit distinguishable from the implant crown in case you had to go back and access that screw at a later time. Obviously, this screw access hole can't be coming through the facial surface of an incisor, so this is why the implant has to be planned thoroughly ahead of time to ensure proper placement and angulation of the implant so that the crown and this screw access hole can be angled in a proper direction. So now the pros of this screw retained crown, one of them I already mentioned, is that it can be removed at a later time. All you have to do is take out the composite plug, take out the Teflon tape, and then you can take the screw out, remove the screw, and take the crown off, clean the components, and do other things that are beneficial. You have no cement to worry about with the screw retained crown, which is a benefit. We'll talk more about that in just a little bit. And the big one is that it takes up less vertical restorative space than the cement retained. So it's better for restricted restorative space areas. Now the cement retained crown is where the abutment is attached as a separate component from the crown. So these two are now separate, and you can have either the one-piece abutment with its own screw or the two-piece abutment with a separate screw. So, like I say here, the abutment is attached separately to the implant. The pros for this one are that there's no screw access hole. So it's typically better for anterior teeth and incisors because now we don't have to worry about having a screw access hole in an in an aesthetic area that could compromise our final result. The big con is, well, I guess there are two of them. Once it's cemented, it can't be removed unless it's physically cut off. And the one I have listed here, which is probably most frequently tested, is that cement may be trapped subgingivally. And so if it's trapped under the gingiva, it can cause peri-implantitis. So remember, that's essentially periodontal disease around an implant instead of around a tooth. So you have the same symptoms. You have gingival inflammation and bone loss. And this is a big, big problem. And cement, a lot of research shows that cement can be a big cause of this. So that's a big negative, and typically why it's considered standard of care after placing any implant, but particularly for cement retained implants, to take a periapical radiograph or bite wing, and so you can see if there's cement that was left over and not cleaned out after placement. All right, so those were the 4 components of implants. Now let's talk about one-piece versus two-piece implants. So the one-piece implant, and this is not to be confused with the one- and two-piece abutments. The one-piece implant is where the implant body and the abutment are physically attached together. And so this whole component, now we don't even have an abutment screw, we just have the abutment and the implant combined together, and they're drilled into bone as one unit. And one helpful way to view the abutment component is as the quote-unquote crown prep of this metal tooth. And it's like the metal crown prep that the implant crown will sit onto. And the problem with a one-piece implant is that you cannot correct the angle between the two components because they're attached as one piece. Whereas once an implant's placed and maybe you want to correct for an angulation error, you can purchase an abutment that has a certain angle built into it, and so you can correct that post-implant surgery. The two-piece implant is much more common, and the implant and the final abutment are separate components. And so the final abutment and the crown are typically placed at the same appointment, usually several weeks after the implant has been placed, to allow the bone to heal and osseointegrate, which again we'll talk about a little bit later. And so once the abutment is in place, the crown can either be cemented on top, which is the cement retained, or the crown, which includes the abutment, are screwed together into the implant, which is the screw retained crown. All right, let's talk about that anti-rotation component that I mentioned before. And so the anti-rotation component can take several different forms. Here we see an internal hex, this is the top of the implant body, and it has this index that's built into the inside of the implant so that when you place an abutment, it can only go in a certain amount of ways. It locks in like a lock and key so that once the abutment is fully seated, it can't spin around and rotate and rock back and forth. Here's an external hex, which shows a similar index, but this time this hexagon is going to lock into the abutment in this direction. This way, the abutment is going to lock down into the implant body. But both of these are providing the same objective: to prevent rotation of the abutment and to provide stabilization of the abutment. So essentially, it's preventing spinning and preventing rocking back and forth of the abutment. And spinning and rocking are very undesirable outcomes. So having this index to lock the various components together helps tremendously. And again, just to recapitulate this, the anti-rotation component can only be involved with the two-piece abutments, because the one-piece abutment has to screw down as a uniformly conical shape, so it can't afford to have this kind of locking hex mechanism. All right, this is another thing that I mentioned before, and it's another great topic to talk about. And this is the topic of integration. So, osseointegration is a very desirable feature of titanium implants. The great thing about titanium, and a bit more recently zirconium, is its biocompatibility and the ability to osseointegrate with bone. So osseointegration refers to a direct structural and functional connection between ordered living bone and the surface of a load-bearing artificial implant. So you usually want to check osseointegration before you place the final abutment and certainly the final crown, so that no mobility would be an issue. Once an implant has properly osseointegrated, it should not be mobile at all because it's directly structurally and functionally connected to that bone, so it's not going to move around. On the opposite side of the coin, fibrous integration means that we have a presence of fibrous tissue between the implant and the bone. So there's going to be some mobility, and this is a failure of osseointegration and therefore a failure of implant placement. So along with this concept of placing the implant, we have primary and secondary stability. Primary stability is when you first place the implant, how well the screw threads lock into the bone that is already there. Secondary stability refers to osseointegration. So after osseointegration occurs within a few weeks, new bone is formed that locks into that titanium alloy. So in this helpful graph, we start out, here's the y-axis is stability from 0 to 100%, and the x-axis is showing weeks, 1, 2, 3, 4, and so on. So we start out when we place the implant with very good primary stability. We're just screwing like a screw into a block of wood. We're screwing in that implant into bone. So we start with really great primary stability, then there's some resorption occurring, and we have a stability dip before the secondary stability takes effect. So once we hit to around the 4-week mark, then we start getting osseointegration. So new bone is forming, healing, and is locking into that titanium alloy. So eventually, that secondary stability with the new bone takes over from primary stability and creates a successful outcome. Now you can imagine if we don't have osseointegration and we have fibrous integration, that blue line never happens. And then we just get more and more mobility, and that implant will be spinning and rocking about, and it would be a failure. So we have to talk about bone quality, because not all bone is created equal. And so in this list, implant success rate goes from high to low. So from the type 1 bone is pictured here on the left. This is dense cortical bone. It provides the best primary stability, but it does have some poor secondary stability due to poor blood supply, but that initial bone is so nice and dense and provides a great amount of primary stability to work with. This is found in the anterior mandible region. And then we go to type 2, which is found in the posterior mandible. Type 3 is found in the anterior maxilla, and type 4 bone is found in the posterior maxilla. So type 4 is soft medullary bone, has very poor primary stability, and so if you get very poor primary stability right off the bat, you're not going to have opportunity to create great secondary stability, even though you might have a good blood supply. Now, depending on what sources you look at, some people might say, well, type 2 and type 3 are actually the best for implant success because you get a good balance of primary and secondary stability. But I will say for the board exam, know that type 1 is the best, type 4 is the worst. In other words, anterior mandible is the best place to place an implant, posterior maxilla is the worst place. And I've definitely seen these questions on the board exam, absolutely. So definitely know type 1 through type 4 and what regions they're associated with. Oh, here's another great slide. I would put red text on this entire slide if I could, because this is probably the most valuable information in this whole video for the board exam. Where to place an implant and what numbers to remember for staying away from certain structures and being careful where to place them. So when we place an implant, we want to be at least, or at minimum, 1 millimeter away from the buccal plate, the lingual plate, the inferior border of the mandible, the maxillary sinus, and the nasal cavity. So when you place an implant, let's say it's 4 millimeters wide, we need to make sure there's at least 1 millimeter of bone buccal to that and 1 millimeter of bone lingual to that. So in other words, for a 5 millimeter implant, which is a little bit wider than what it should be, that means with 1 millimeter buccal, 1 millimeter lingual, we would need a total buccolingual dimension, a buccolingual width of 7 millimeters. So they could ask that if you have an implant diameter of 3 millimeters, how much buccolingual width would you need? And you need to know that you need 5 millimeters. And that's coming just from knowing this number. From adjacent natural teeth, another great question. You need at least 1.5 millimeters of space between the implant and the adjacent tooth. So this is another great question. If you were placing an implant in number 30 and you had 29 and 31 to either side, let's say the implant is 3 millimeters in diameter, how much space mesiodistally would you need? And so you need to know, well, I need 1.5 on the distal side, 1.5 on the mesial side. The implant takes up 3 millimeters, so I would need 6 millimeters total. Things like that. Very simple math problems that all you need to do is recall these numbers here. We need to be 2 millimeters away from the inferior alveolar nerve, so we need at least 2 millimeters of space right here. That's called the safety zone. We need 3 millimeters of space between adjacent implants. So for away from natural teeth, this is at least 1.5 millimeters of distance. Between two implants, this needs to be at least 3 millimeters of distance. Might be a little bit close in this image. And this one, we definitely have at least 3 millimeters of space between those two implants, which is good. Although you can see that it's right up against the inferior alveolar nerve, which is not good. We need at least 2 millimeters of space there. And lastly, we should be at least 5 millimeters away from the mental nerve or the mental foramen. And that's due to the anterior loop. This nerve loops around before it enters the mental foramen, and so it can be deceiving because you might place the implant just anterior to the mental foramen, but you still hit the nerve because it loops around anteriorly. So we have to be at least 5 millimeters away from that structure. So these are all really, really important numbers to memorize. Absolutely. I can't stress enough how important this slide is to memorize. All right, now that we're deep into the subject of surgery, let's talk about 1 versus 2 stage surgeries. So 1 stage surgery involves placing the implant and a healing abutment in one visit. So the healing abutment, or the cap, the healing cap is shown here, and it sticks out of the gums, essentially like an earring in an ear is the best way I can describe it. And so that helps to sculpt and mold the soft tissues around this implant healing abutment in order to frame the restoration appropriately. So when it's time for the patient to come back, you remove this temporary healing abutment and you put in the final abutment. That soft tissue has a really nice collar and provides a great emergence profile for the implant. The 2-stage surgery means that we place the implant with a cover screw, which is a thin little disc that you screw into the implant. It's another temporary measure, but this time we're covering it up with gums. So the healing abutment sticks out of the gums. This one is completely covered with primary closure. And it's a 2-stage surgery because the next time they come in, we have to then open the gums and then place the abutment at the next visit. And this could be either the temporary healing abutment shown here or that final abutment that we saw in the previous slides. So why would we do two-stage surgery? Because most patients would want to just have one surgery and be done with it. Well, two-stage can be beneficial for three main reasons I can think of. If you have poor primary stability, so say we're working in the posterior maxilla, and we want to keep all occlusion off of it. So we would place this cover screw, and so we make sure that there are going to be no biting forces on the implant while it's healing and secondary stability is taking over. The second reason would be if we need to place a graft, so we'd want to close up the gums so that the bone heals properly. The third reason is that if we have a medically compromised patient, so that immunocompromised or unstable diabetes from that contraindication slide, so this technique would allow primary closure over the implant site, which poses less infection risk. Alright, how about the impression? So once healing is complete, a final impression is made so that the crown and the abutment are properly oriented. So we use what's called an impression coping, which is used to transfer the location and angulation of the implant to a master cast. Here is the impression coping. So you can imagine the implant has been screwed in. Maybe we did a one-stage surgery, we took out the healing abutment, and now we're ready to take our impression. Or maybe we did a cover screw first, now we opened that area up, and we're ready to take an impression. So the coping attaches into the implant in the mouth and allows you to record the angulation of the implant, which without a set of 2D x-rays or a 3D x-ray, we can't see the implant angulation once it's screwed in because, well, as you can see here, it's surrounded by gums and bones, so we can't see anything. So we screw in this impression coping, which allows us to see and which allows us to imagine where that implant is without any second guessing. So this slide is totally beyond the scope of the board exam, but I just wanted to include this information, number one, because I'm so excited about it, but number two, because I know a lot of you are really curious about implants. So the open tray impression is when you physically drill a hole in the plastic impression tray so that you can, once the impression is seated, you can access the coping once the material sets. So there's a hole in the impression tray. We might put a little piece of cotton in this little tiny screw hole here so that we can access it without plugging in the impression material, that polyvinyl siloxane getting set into that screw hole. So we can go back and later, once the material sets, unscrew this coping from the implant, and then there's a record of where that impression coping was, so you can later seat it in that spot. The closed tray impression is when you take the impression like normal, and then you remove the impression, and then there's a little space in the impression material where that impression coping was. So then you later would unscrew that impression coping and then seat it in the spot where it was on the impression. So each technique has pros and cons and utilizes a different looking impression coping. This is an open tray impression coping. So once you have that impression, you put a little pink stuff around the coping to block it out and represent the gingiva, called the gingival moulage. Then you screw this thing in, which is called the analog, into the coping. You pour it up like any old impression, and you get a master cast where the analog will essentially be in the exact same position embedded in that stone of the cast as the implant is in the mouth. So the analog provides your precise replication of the implant positioned in the mouth. So that's a very, very cursory overlook at implant impressions, just to introduce some of these concepts and terms. So socket preservation is something that we see in the oral surgery world, and this is to maintain the height and width of the alveolar ridge after a tooth extraction. So the most important part about socket preservation is to have an atraumatic extraction. So we're shooting for potentially a simple extraction, right? A non-surgical extraction. We're not breaking off the buccal plate of the extracted tooth. We're limiting any sort of trauma to the area. And then we do a lot of the same things we do following an extraction. We irrigate that extraction site very thoroughly. We remove granulation tissue with the curette. But then we also place bone graft material, and we like to cover that with a resorbable collagen membrane. If you remember from the periodontic series, that's some of the things that we talked about with guided tissue regeneration. It's a similar process. We want to regenerate the bone in that area to help fill in that socket, but also to limit any bone loss in a buccolingual or occlusal direction. Primary closure with this procedure is actually unnecessary. Biologic width. This is something I have an entire video just dedicated to the Farrell effect and biologic width, but here it's a little bit different. We're talking about the implant being placed into bone. This surface that's contacting bone is roughened to help with osseointegration. The smooth surface is contacting the soft tissue here, the soft tissue collar. And so the gingival fibers orient next to that implant in a parallel direction. So it's parallel with the implant cuff, and that's the area notated with the A here. And so gingival fibers orient next to the implant parallel with the cuff, and this could be asked on the board exam, how the gingival fibers are oriented next to an implant. The other important thing to note here is that the tooth has a periodontal ligament. An implant does not have a periodontal ligament because it's directly contacting the alveolar bone. So without a periodontal ligament, there's technically no periodontium. So the implant is unique in that matter as well. A surgical stent, I also mentioned this earlier in the video. This is referring to guided surgery. So we have a stent made, we place in the patient's mouth, and this metal sleeve helps to guide the implant drill as we're drilling the hole and delivering the implant. So the surgical stent can provide LAD for location, angulation, and depth of placement. So make sure any and all implants being placed are aligned properly with the surgical stent, so it can help in that matter. And finally, we're going to talk about implant success and implant failure and the features that go along with each of those. So the four main characteristics of implant success are that it's immobile, and we talked about the fibrous integration, having that fibrous layer in between the implant and bone, and how that's not desirable because we want that bone to be fully osseointegrated and immobile. There should be no peri-implant radiolucency. There will be some peri-implant bone loss, and particularly there's some initial bone loss that's to be expected, but virtually no bone loss afterwards. So less than 0.2 millimeters per year after the first year. And then absence of symptoms, namely pain, infection, paresthesia, those sorts of things. So we should have no movement, no radiolucency, virtually no bone loss, and no symptoms. So therefore, mobility, pain, radiolucency, and peri-implant bone loss would be all signs of implant failure. Gram-negative anaerobic rods and filaments are often associated with implant failure, peri-implantitis, those sorts of things. And one more important number for the board exam, 47 degrees Celsius for 1 minute or 40 degrees Celsius for 7 minutes is enough to compromise osseointegration. So again, this goes back to one of those first slides I had to reduce the amount of heat generated with a sharp drill, copious irrigation, and sequentially enlarging the osteotomy is so important because we don't want to compromise osseointegration before even the implant is placed. All right, so that's it for this.
you.